Good morning, everyone, and welcome to Heart Center Grand Rounds. Today I'm very pleased to have with me Dr. Neal Kleiman. And before I introduce Dr. Kleiman, who really needs no introduction, let me just remind everyone that if you have questions for Dr. Kleiman at the end of his lecture, please text those in now at 37607 and text the word DeBakey, or you can go to pollev.com/DeBakey and enter your questions there. And then we'll try to have a little bit of time for some questions from the audience or from a couple of panelists that we have as well that I'll introduce in a few minutes. So obviously Dr. Neal Kleiman, well-known, internationally regarded interventional cardiologist. Neal is the director of the Cardiac Catheterization Lab and the director of the Interventional Cardiology Fellowship here at Houston Methodist Hospital. Neal is really a pioneer in interventional cardiology when it comes to stents, when it comes to platelets, and I think he's reinvented himself in recent years with all the structural heart interventions as well. Neal did his medical schooling in New York at Columbia, and then came down here to Texas where he was a resident and fellow at Baylor College of Medicine and has been on the faculty here at Houston Methodist since that time. Neal obviously is very acclaimed as far as having trained a large number of cardiologists, interventional cardiologists that have gone out into practice and academic careers. And he's very well published as well with nearly 300 publications in the literature. So, and the other thing for those of you that know Neal is he always likes to keep people guessing. And so today's topic, which none of us know what it is, but we know it's going to be very entertaining and exciting. Less is more, the peculiar tale of ... So with that, Neal, welcome.
Well,
and we look forward to hearing your talk.
Thank you for that very nice introduction. As usual, it was well overstated. I don't think I deserve any of it. Interestingly, this is the first time I've ever given grand rounds seated. And it's also the first time in about 3 months that I've worn a tie. And really, fortunately, I was able to remember how to tie it this morning. So I think we're off to a good start. So as Dipan said, I wanted to keep people guessing. I'm going to talk about the peculiar tale of platelets and stents. And it's just peculiar that we've been discussing this for nearly 2 decades and really still have not yet arrived at an answer that's A, satisfactory, B, widely known, and C, widely accepted. So let me start by showing you a slide of a patient who didn't have an MI. So this is a patient I actually inherited. What you see on your left is she had originally presented with a proximal LAD lesion. She underwent a series of stents. Take a look at on the left. I've clipped some notes from our nurse practitioner from Epic who saw her and included kind of a detailed history. So she had the first set of stents shown on the left, and then for some reason aspirin and Plavix were stopped. We don't know when, but after not too long a course, and never restarted. She was admitted with what turned out to be GI complaint. She subsequently underwent cath, shown in the bottom right, had 2 areas not of stent thrombosis, but these are in-stent restenosis. We IVUSed them. These were not thrombotic lesions, and restented her. But the point is, this is a patient you certainly would not have been surprised had she developed a clot in the stent and stent thrombosis. Restriction to inflow, restriction to outflow. You see there's a stent in the middle overlying that septal branch, a stent distally. By everything we've been taught and everything we've been teaching, you'd expect this patient to have had an MI, which she did not have. So let's look back at the history of the universe. Year 0, the Big Bang, then some relatively unimportant things happened until 1977. And take a look down at the bottom. That's, as many of you will recognize from the last 2 grand rounds I gave, that's Grunzig's workbench. This is what he used to develop the first PCI balloon. If you look really carefully at the left-hand side of that picture, you can see a bottle of wine. I'm not sure what that was used for, although I can guess. So this was published for coronary work in 1977. And incidentally, at around that time, cardiologists were becoming interested in aspirin, starting about 1980 with the Paris trial of aspirin and dipyridamole. And then as PCI developed, between 1985 and 1987, there were a series of small studies that showed that using aspirin after PCI reduced your likelihood of clotting the vessel and developing an MI. These are important, and we will come back to those. 1993, Antonio Colombo first described the use of dual antiplatelet therapy at the ACC meeting that spring. Stent usage took off, much as coronavirus has, just as rapidly. 1995, the first randomized trial confirming that treatment was published by Marty Leon. That was the STARS trial. And then you get to 2014, and the Dapped trial was published. So these are the big landmarks in developing our concept of antiplatelet therapy in patients who received stents. Much of this is old hat, much is history. These are the randomized trials demonstrating that the combination of aspirin and the P2Y12 antagonist ticlopidine was superior for preventing stent thrombosis and its clinical manifestations, death, MI, revascularization. At around the same time, actually a little later, as DrugEluting Stents came out, Dr. Colombo's group published this study which showed that the number one factor for stent thrombosis, even though it was fairly uncommon, but the number one factor was premature discontinuation of antiplatelet therapy. Now again, this is a mixed bag. Some of these people stopped it because someone told them to stop. Some stopped because they had something else clinically going on that mandated that they stop it. And remember, that latter group is already sick, and they are almost by definition more likely to have adverse events. So every report that you see represents that mixed bag. Interruption and cessation, different things. Instruction that it's just time to stop dual antiplatelet therapy, and a worried warning that, yeah, you better stop it and stop it now, we're already in trouble. Two different things that frequently get mixed. And then fast forward from there by a year, 2006, there are concerns about the late safety of first-generation drug-eluting stents, starting with this report in The Lancet of thrombosis of two of the first-generation stents, despite IVUS optimized stent placement. One was, most of these occurred more than a year after implantation. Shown at the bottom right is a histologic slide that sort of became our go-to slide, showing that stent coverage was incomplete as the stent endothelialized, and at the areas of incomplete coverage, thrombi started to form. And then in 2006, the Firestorm started. People got concerned about late thrombosis and drug-eluting stents. This started at the European Society of Cardiology conference. There were a number of presentations of large series with findings such as those shown on the right. Drug-eluting stents shown in gold. Actually a lower rate of subacute thrombosis and a much higher rate of late thrombosis. And then shown at the bottom right, several studies such as this one by Eisenstein at Duke, showing that patients on prolonged clopidogrel as well as aspirin had lower rates of death or MI. So the indication here was that the longer you continued dual antiplatelet therapy, 2 drugs rather than 1, the better with drug-eluting stents. Whereas with bare metal stents, a shorter course was tolerable. At about the same time, another interesting set of observations was made, and it's important because this defines the balance that we'll spend the rest of this 3-hour lecture discussing. When people looked at the risk of bleeding and what its downstream effects were, there were some shocking findings that were repeated over and over and over. And there is not a single study in the literature that refutes this. These are our own data from when we did the event registry published by Lindsay et al. If you look at the risk of dying in patients who had bleeding, as you might guess, it's better not to bleed. No kidding. Well, there's a risk of dying that doesn't go away when you adjust for things you can find in the patient's overall risk of mortality. And if you look at the odds ratios, they're all in the same direction as myocardial infarction. So an MI is a bad thing to have. Bleeding is probably a worse thing to have, at least in this model. And then multiple other investigators at the same time found the same thing. This is Roxana Marin's publication from the Acuity trial. Look at the risk ratio, the hazard ratios shown in the forest plot. Risk for death, according to bleeding. Well, interestingly, in this study, your risk was related to at what time course after the stent, after your acute coronary syndrome you bled, major bleeding, transfusion. This looks very similar to MI. What I told you initially was a little incorrect. The time dependence is for MI, not for bleeding. For bleeding, it's relatively time independent. But take a look. If you had a subacute MI, meaning subacute stent thrombosis, shown in the bottom two, or a late thrombosis, your risk for dying was a little bit less than actually if you'd had a bleeding episode. Now, one thing you'll learn is these are not independent events, but it just points out that bleeding was found at around this time to be a serious event. So the question came up, less is more. Mies van der Rohe, the architect, popularized that statement in the late 40s and early 50s in his architecture work. Statement originally came from the English poet Robert Browning in the poem Andrea del Sarto. So I'm going to talk about is less more. What if we give fewer antithrombotic drugs? Is that going to be a better thing to do? So as I said, we've been debating this. Everyone knows the answer. Problem is that none of the people on this, watching this Zoom, can agree with any of the other people as to what that answer is. Michelle O'Donoghue published this in the Heart.org several years ago. She said 2 years after the Dapped trial, we're still debating. We should update this. I originally updated it to 3 years. Now we're 5 years out from this publication, almost 6 years from the Dapped trial, and we're still really uncertain. Last time I looked, there were approximately 20 randomized controlled trials of Dapped duration. Last time I looked, 192 meta-analyses. That's 5 meta-analyses per trial. Between 2015 and 2020, they weren't all concordant. In fact, they weren't even close. So I'm preparing this grand rounds, and what did I do? Well, I emailed Roxana Marin, who's really established herself as the dean of this topic, and I said, Roxana, how many randomized trials are there now? And as of last week, look at the bottom of the slide, this is her answer. I have lost count. Well, in fact, we all have. There are lots of randomized trials, and it's still very challenging to put them together. So let me show you a few pieces of data that I think will help formulate things. Now, one thing you need to realize is if you look at the early trials, short versus long duration of Dapped, according to the numbers. A very interesting publication came out by Giustino that looked at angiographic characteristics of the lesions that were stented in these trials. Were these simple or complex lesions? And take a look. As you might guess, the more complex the coronary artery disease, the more complex the stenting, so more than 3 vessels stented, 3 lesions treated, 3 stents, long stents, bifurcation CTOs. The more of these characteristics a patient had, the more benefit they got in prolonged Dapped than short Dapped. And you might imagine that it takes longer to endothelialize those stents. Take a look down at the bottom, though. In the randomized trials, 82% of patients had none of these characteristics. So these largely were trials in patients with simple stents, probably in whom it was really tough to do any harm. But all those data resulted in these 2 sets of guidelines that are probably illegible to you unless you've got really good eyesight. These are the ACCA H8 guidelines 2016, and they recommend that if a patient has stable angina, gets a drug-eluting stent, 6 months of Dapped, patient with an acute coronary syndrome, 12 months of Dapped. If they get a bare metal stent, a shorter duration of Dapped, 1 month, unless they are at high bleeding risk, shown by the red asterisks, in which case you now get a Class 2B indication for a shorter duration of Dapped. Similarly, in the European Society of Cardiology guidelines, they're almost identical. They're both illegible on slides, but they both tell you almost exactly the same thing, and they're all concerned about the presence of high bleeding risk. There's only one problem. If you take a look at the data and you categorize patients according to either high bleeding risk, low bleeding risk, high thrombotic risk, or low thrombotic risk, there is a tremendous amount of overlap in the risk models. So these are taken from the Paris registry. Take a look at the total number of patients who are either at low bleeding risk and high thrombotic risk, shown in the first bar, or high bleeding risk and low thrombotic risk, shown in the bar to your far right. That represents only 6.6% of the patients. So anytime someone tells you, well, select patients who are at high bleeding risk but low thrombotic risk, or select patients who are at high thrombotic risk or low bleeding risk, time to tell them to get out of the ivory tower, look at the real world. There are almost no such patients. Now, the other issue is, what about the rest of the vasculature? Maybe we should be treating patients with prolonged Dapped. So this is the Dapped trial, published in late 2014. In this trial, patients had PCI. Almost all of them had drug-eluting stents. Everyone was treated for a full 12 months with aspirin and either clopidogrel or prasugrel, which is Effient. So 12 months of dual antiplatelet therapy and then randomized. So obviously, as you might guess, in that 12-month period, a number of patients were excluded because they'd either died, had an MI, and people didn't want to take them off clopidogrel, repeat PCI, CABG, stroke, or major bleeding. These aren't patients you'd really be interested in randomizing, but the rest were randomized, double-blind, placebo-controlled, to receive for 18 months either single antiplatelet therapy consisting of aspirin or dual antiplatelet therapy consisting of the combination of aspirin and ethenopyridine. As I said, almost all in this randomized portion, at least the reported portion, had drug-eluting stents, mostly first generation, and most of the patients received clopidogrel. Here are the findings. You're all familiar with these. Reduction in the two co-primary endpoints, cumulative stent thrombosis, remember, between 12 and 30 months, so everyone had gone for a year before they're randomized and analyzed, 0.4% versus 1.4%, a 1% absolute difference. And the co-primary endpoint, major adverse cardiovascular or cerebrovascular events, again, favoring dual antiplatelet therapy with what might be regarded as a catch-up phenomenon that's still debated, between 30 and 33 months when the ethenopyridine was stopped. Interestingly, non-stent thrombosis, different anatomic distribution than the stented vessel, also reduced by 55% in this group. So some of the benefit occurred outside the stented vessel, and as you might guess, bleeding was lower with one antiplatelet drug, meaning aspirin, versus two antiplatelet drugs. So the legend here refers to the duration of Dapped. So about a 60% reduction in the risk of TIMI, moderate or severe bleeding. Gusto severe bleeding, which has to be really bad, to make a long story short. A low frequency event, not different. Remember, of course, these are patients who were already selected because they had done well during their first year of dual antiplatelet therapy. So there are two ways to interpret this. If you're prolonged therapy, reduced frequency of MACE, reduction in non-stent related MI, reduced rate of late stent thrombosis, no difference in severe bleeding. On the other hand, there was more TIMI-related bleeding. There was higher all-cause mortality, a possible increase in cancer mortality. Again, low frequency event. We don't have time during this lecture to discuss it. And, we keep getting better and better stents, even within Dapped. The second generation stents had lower event rates than the first generation stents, although the pattern was still present. So, again, the trial was the most rigorously done of the randomized trials up to that point. Still a fair amount of debate. So, going from Dapped to SAPT, there are important questions. The word stent, is the letter S or the letter C silent? Think about that. What does the S in SAPT refer to? Does it or should it refer to aspirin, or should it refer to the P2Y12 antagonist? Clopidogrel, prasugrel, or ticagrelor? What should single antiplatelet therapy consist of? So let's talk about the rest of the history of the universe. Again, Big Bang, a couple of unimportant things, formation of the Earth, etc. 2014, though, Dapped study comes out. 2015, we get the Zeus study and the Leaders Free study. 2018, we get the senior Dapped trial. 2019, we see some remarkable studies that I'm going to talk about. 2020, we get Onyx Clear and Onyx One Clear. At the same time, we get better stents that are probably less thrombogenic, thinner struts, better, possibly antithrombotic polymers, and we start to get good with adjunctive imaging. At least some of us start to get good. Some still struggle. Okay, so let's back up a little bit. SAPT. What does single antiplatelet therapy mean? Well, as cardiologists, whether you take a tablet in the morning or not, aspirin is in your blood. No getting around it. It's part of the way we think. I won't go through the entire history of aspirin. It's really pretty impressive. But remember, for a long time, during my formative years, and if you're older, during your years where you started to mature, if you're younger than I am, which means less than age 64, during your mentor's formative years. This was the only antiplatelet drug around, and compared to nothing, it seemed to work pretty damn well. So take a look down at the bottom. This is a recommendation from Charlie Hennekins and Valentin Fuster. Long-term aspirin therapy confers conclusive net benefits on risk of subsequent MI, stroke, and vascular death among patients with a wide range of prior manifestations of cardiovascular disease. So pretty tough to get around aspirin. Pretty tough scientifically to say we're going to do a study with no aspirin. Pretty tough emotionally for some of us who believe in our heart of hearts that it's a good thing. But let's talk about that. Actually, it has been done. If one looks on the left-hand slide at aspirin compared with clopidogrel, biologically, clopidogrel is a more potent drug. I've shown you ADP-induced ADP-induced platelet activation measured by measuring P-selectin, aspirin shown in black, clopidogrel and the combination of clopidogrel shown in the light and shaded bars. There's less activity. A higher bar here means platelets are more revved up, more activated, more likely to form clots. So if you've got a stent in someone, you want those bars to be lower. If you're worried about them bleeding, you're not so sure. So based on findings like this, the Capri trial was done. Published in 1996, this was a broad spectrum trial of patients with MI, stroke, or peripheral vascular disease. The endpoint was stroke, MI, or vascular death. A benefit for clopidogrel alone versus aspirin alone. There's no Dapped in this trial, but there was a significant, although small, reduction in events for patients receiving clopidogrel compared with those receiving aspirin. It was most pronounced in patients with peripheral vascular disease, who probably have more severe atherosclerosis than the rest. So as we fast forward from then to 2019, people did get a little more daring. So I'll show you several trials that looked at monotherapy, changing the S in SAPT from aspirin to a P2Y12 antagonist. The early trials were mostly clopidogrel. The later trials I'll show you used ticagrelor. So this is the first one, the SMART Choice trial. Nearly 3,000 all-comer patients with drug-eluting stents. The stent types are shown in the bracket. They're all currently used stents. The randomization was aspirin plus a P2Y12 antagonist, so Dapped, for a year. Most of those patients received clopidogrel, versus aspirin and a Dapped, aspirin and a P2Y12 or Dapped for 3 months, followed by a P2Y12 antagonist alone for the rest of the 12 months. So I'm not going to show you all the guts of each of these trials. Remember, for most of these trials coming up, ischemic events are relatively uncommon. They're low-frequency events. When you add them all together into major adverse cardiovascular events, or MACE, you can see the event rates are low. The p-value is significant for non-inferiority, although there's a fairly broad margin. So, at least based on this study, non-inferiority in terms of ischemic events and a benefit in terms of bleeding events. Stop Dapped 2, another trial published in 2019. Slightly more than 3,000 all-comer PCIs with cobalt chromium everolimus eluting stent, the Xience stent. Aspirin and a P2Y12 antagonist of the operator's choice for a month. Remember, the first month is when stent thrombosis rates are highest, followed by clopidogrel for the rest of 12 months. So dual antiplatelet therapy for 12 months versus dual antiplatelet therapy for 1 month and clopidogrel alone for the rest of the year. So now we've changed the S in SAPT in both of these trials from aspirin to clopidogrel. And again, take a look. Benefit for single antiplatelet therapy with the P2Y12 antagonist, mostly driven by a difference in bleeding. Again, ischemic events, low frequency in these studies, as they are in all-comer PCI patients, but not meaningfully different. So the question is this, 2020. If you had to choose your antiplatelet drug comfortably, you'd choose one that was probably a little more powerful if you're using one, and certainly one that was a little more reliable in terms of patient resistance. So shown here, I just pulled one of the slides looking at the development of ticagrelor. This is from the early days when it didn't yet have a generic name assigned to it, so it was AZD 6140, studied in varying doses, shown by the 3 lines on the bottom. Take a look. Greater reduction in platelet aggregation, which is represented on the y-axis. So lower on the y-axis means it's more powerful, less aggregation, compared with clopidogrel, shown in bright green. Take a look at the error bars, which reflect the consistency of the response. Much more consistent. So it's both more potent, producing more profound inhibition, and more reliable, less of a variable response. So if you go back and look at some of the short Dapped duration trials and look at what was used as part of the antiplatelet regimen and how often were these second generation P2Y12 antagonists, meaning prasugrel or ticagrelor, at best it's slightly more than half the cases. So there's not consistency within the trials, and the use of clopidogrel was still really fairly dominant. But let's take a look at the trials that are more recently published. So first of all, the Global Leaders trial looked at a slightly different approach. They said, okay, what are the guideline recommended treatments? So let's start with the bottom 2 bars. Acute coronary syndromes aspirin and ticagrelor for a year. Stable coronary artery disease, clopidogrel, they went out for a year. Then after the first year, they went to aspirin alone. Standard therapy. These are acceptable by guidelines. Guideline-directed medical therapy. This is our bread and butter. The experimental strategy, shown at the top. Dual antiplatelet therapy for only a month. Aspirin and ticagrelor, or Brilinta. This was an all-comers PCI population, nearly 16,000 patients. Open-label design, 130 centers. All comers, any lesion, unrestricted use or type of drug-eluting stent. Unrestricted use of drug-eluting stents. Now, how many stents you wanted to put in, wanted to include a CTO, a bifurcation lesion, etc. These were all biomatrix drug-eluting stents which used a bioabsorbable polymer. So it's not a stent that's readily available in the US. These are the outcomes. It was designed to test superiority of 1 month of aspirin and ticagrelor followed by 2 years of ticagrelor alone versus Dapped, according to guidelines, for a year, followed by aspirin monotherapy. So a little bit of a mix here. Takes a little bit of time to sit down with this and get your arms around it. But the point was they missed their superiority endpoint. Although if you take a look at the relative risk and the confidence limits, they just barely missed it. The upper 95th confidence limit is 1.01. Take a look at bleeding. Again, barely missed that. But again, clinically, not much difference in the frequency. All comers included low-risk patients, low frequency of events. A sub-study of that, known as Glassy, published at the end of last year. A little more rigorous central adjudication, broader composite. This was done only at high-volume centers. Report non-inferiority for ticagrelor in terms of reducing ischemic events, but not superiority. Interestingly, bleeding risk was lower for ACS patients, but higher for those with stable coronary artery disease, probably because stable coronary artery disease for the first year got aspirin plus clopidogrel before they went to aspirin alone, whereas acute coronary syndromes in the experimental arm got aspirin plus ticagrelor and stayed on ticagrelor. So a little bit lower bleeding risk for ACS, a little bit higher for stable CAD. Again, using a stent that we don't use in the US, it's a little hard to wrap your arms around this study completely, but I think it shows us important points, mainly that going to single antiplatelet therapy is unlikely, with ticagrelor, is unlikely to be a terrible thing to do. And there probably are some benefits to do it, although, as I mentioned, they just barely missed their primary endpoint. So again, back to this slide that I showed you earlier. Thrombotic risk and bleeding risks track together. Most patients have some degree of both. So Leaders Free, or rather Global Leaders, was an all-comers trial. What if you studied this in patients in whom the difference was more important? Higher risk patients. So in fact, that's what the Twilight study was. So in this study, patients had to be high risk to be enrolled. So take a look at the bottom left. They had to be over age 65, or women, or troponin positive, or have peripheral artery disease, or have diabetes, or have CKD. Now, if you're thinking, you're wondering, high risk for what? Ischemia, stent thrombosis, or bleeding? Well, again, if you've been awake for the last 36 minutes, you'll remember high risk for either one of those two, or really high risk for both. So first year of therapy, aspirin plus ticagrelor. After a year, if you didn't have an event while on dual antiplatelet therapy, you were randomized and double-blind assigned to continue the next year on either aspirin plus ticagrelor or ticagrelor plus placebo. So either dual antiplatelet therapy with ticagrelor or single antiplatelet therapy with ticagrelor alone. Now, again, ischemia is still a relatively low frequency endpoint. It's tougher to design a study around it these days, particularly if you're starting a year after the stent went in. But the bleeding risk mostly remains the same, maybe not identical, but if it's present at 6 months, it's present at a year. Patients don't get younger, diabetes doesn't disappear. So take a look. Primary endpoint, bleeding academic research consortium, 2, 3, or 5. These are actionable bleeding, actionable or worrisome degrees of bleeding, non-bypass related. So take a look. Single antiplatelet therapy with ticagrelor did considerably better. Hazard ratio 0.56 after 12 months of treatment. So a 44% reduction in the risk. Confidence limits well below 1. P-value 0.001. What about ischemic events? Well, again, low frequency. The study wasn't designed to look for superiority here, but take a look. Identical rates at the end of the year. Superiority, no way. Non-inferiority, absolutely. P less than 0.001. So again, ischemic events, single antiplatelet therapy with a new P2Y12 antagonist, superior in terms of bleeding, non-inferior in terms of ischemic events. And when one looks at this study, all the sub-studies follow the pattern of the major study, whether it be acute coronary syndromes, complexity of lesions, and most recently at the FSCAI meeting, or virtual meeting last month, it appeared to be independent of stent platform, although we need to see a little more detail to understand that a little better. So that's trial number 2 for single antiplatelet therapy with a newer generation P2Y12 antagonist. Trial number 3 was presented at the ACC this year. Trial design published a year ago. Patients with ACS receiving Osiro stents, which have ultra-thin struts. They're the thinnest struts out there now, and a slowly bioabsorbable polymer, randomized after 3 months of Dapped to ticagrelor monotherapy or conventional treatment. Primary endpoint, net clinical adverse event at 12 months. That is major adverse cardiovascular or cerebrovascular events, death, MI, stroke, stent thrombosis, target vesicle revascularization, and TIMI major bleeding. So 3 months of Dapped, followed by the remainder of the year on monotherapy. Again, aspirin is the med that was dropped versus 12 months of Dapped. These are the primary outcomes. The combined event rate at 12 months, lower with ticagrelor monotherapy than dual antiplatelet therapy, and with a landmark analysis, which again, statistically is a very questionable thing to do, although it plants nice ideas in our minds. That difference is even more pronounced if you start at 90 days. Take a look after 90 days, the total event rate is 1.4% in the monotherapy group. So low in the Dapped group, really low in the monotherapy group. And if one looks at ischemic events alone, these are not statistically significant. The hazard ratio, 95% confidence limits cross 1, but things directionally look favorable for monotherapy, and it looks consistent with the other trials published. So I would say things look pretty good for monotherapy with ticagrelor, the newer generation P2Y12 antagonist, after a shorter course of Dapped, at least in the high-risk patients and possibly more broadly. So what about even shorter therapy? Where do we stand there? Well, this trial I've shown a few times. This is the Zeus trial. Again, the concept we're talking about, high risk. or really low risk, interestingly. But take a look. Most of these patients had high bleeding risk. Some had high thrombotic risk. So more than 50% high bleeding risk and just under 20% high thrombotic risk. If you take a look at the panel that's covered up, at 2 months, about 60% of patients stopped dual antiplatelet therapy, ran to single antiplatelet therapy. And again, if you take a look, this comparison, sorry guys, if one takes a look, the randomization was between a bare metal stent or a drug-eluting stent with prolonged antiplatelet therapy, or actually with shorter-term antiplatelet therapy. So if you got a bare metal stent, you had shorter antiplatelet therapy. But what this is designed to ask is it worth taking the risk of using a drug-eluting stent versus a bare metal stent? And the answer here is clearly yes, and the answer is clearly yes. If the bleeding risk is high, you can get away with shortening the duration of Dapped, probably with impunity. And so this concept was taken a little further. This is the Leaders Free Trial, nearly 2,500 patients judged at high risk for bleeding. And I don't have the list of high-risk features, but you've seen most of them on preceding slides. Treated with 1 month of Dapped. And they received either a bare metal stent or a polymer-free biolimus eluting stent. Again, something we don't have in the US. More than a third of these patients were on oral anticoagulants. Primary endpoints were safety, and that was cardiovascular death, MI, definite or probable stent thrombosis. Out to a year, there's a clear benefit for the drug-eluting stent, even though these patients got a single month of dual antiplatelet therapy. So both in terms of ischemic endpoints and in terms of safety. And what I don't have here is these data are consistent out to 2 years. So again, high bleeding risk, there seems to be benefit for shortening the duration of Dapped. The senior trial, another high-risk group. You had to be more than 75 years old to get into this trial. Nearly half had acute coronary syndrome, slightly more than half had acute, intermediate, or high thrombotic risk scores. Randomized again to bare metal stents versus drug-eluting stents with the Synergy stent. 1 month of Dapped was recommended. Take a look at the bottom panel, which shows the duration of Dapped, and you'll see you get out to a month. Half of patients come off it. So again, what are we doing? Well, we see here a benefit, again, for drug-eluting stents versus bare metal stents, but we're backing into the question of really short Dapped duration in high-risk patients. And although circumstantial, the evidence from these trials suggests, yes, if there's a good reason, you can shorten things with impunity. So now let's get back to 2019, 2020. The Onyx One Trial, presented last year, published this year. These are patients getting the Onyx Resolute zodorolimus eluting stent. Nearly 2,000 patients at high bleeding risk. Again, with the things that should be obvious to you and the things we've gone over a number of times. Randomized to the Onyx Resolute zodorolimus eluting stent versus polymer-free stent. Treated with 1 month of Dapped. About half of these had aspirin, half had P2Y12. Followed for a year for cardiovascular death, MI, or stent thrombosis. These weren't low event rates at a year. Take a look, 17.3% in each treatment group. Stent thrombosis, again, not a low event rate, slightly more than 2%. Nearly identical in both groups. So a current stent, high bleeding risk, you could get away with 1 month of dual antiplatelet therapy, followed by therapy with a P2Y12 antagonist. More recently, presented at this ACC, another similar study with the Onyx Resolute zodorolimus eluting stent, 1,500 all-comer patients, 1 month of Dapped, again, half aspirin, half P2Y12 for their single antiplatelet therapy. Again, in this trial, no control group. There was a performance goal shown in the top right panel. The confidence limits fell well under the limit set by the performance goal. And take a look at 1 year. The rate of stent thrombosis is only 0.7%. The rate of MI is 5%. So again, this trial is not randomized, but it indicates that in the appropriate patient group, high bleeding risk, you can get away with single antiplatelet therapy. So that's what it looks like, but you know, as in everything else we do, there are flies in the ointment. So what are those flies? So first of all, imaging. We're getting pretty proficient at this, and we're getting really comfortable using them. So this is the ultimate study published in late 2018, in which patients getting drug-eluting stent and treated for a year with aspirin and clopidogrel were randomized to either angiographically directed stent placement or optimization using IVUS. And take a look. The rate of target vessel failure at 1 year, if you used IVUS and optimized the PCI, was 1.6%, with a stent thrombosis rate of 0.1%. So maybe we shouldn't even be arguing about Dapped duration. Maybe if you can optimize a stent, make sure it's well expanded, no edge dissection, make sure that you've covered the atherosclerotic segment, maybe you could be sipping coffee instead of listening to this grand rounds. Hell, I think that's what most people would prefer, don't you think, Dipan?
I agree.
Alpesh, what do you think? You're sipping coffee. We're on Zoom. You can have coffee as it is. Okay. But, you know, the truth is we don't always get rid of the atherosclerosis. This is the Dipan PCI study, again, published last year. And what it shows you, to make a long story short, blue is good, red and black aren't good. So in more than 20%, we don't get good revascularization in the target vessel. These are flow reserves after stent placement. It's still inadequate, indicating ongoing ischemia in nearly a quarter of the stents that we place. So maybe we've gotten pretty good putting stents in. Maybe we can do better. I mean, we're supposed to be continually improving ourselves. Maybe this really ought to be motivation to do so. Here's the other big fly in the ointment, atrial fib. I mean, look, guys, there's no getting around anticoagulation. Shown in the bar graphs are the vitamin K antagonist versus placebo trials. A lot fewer events in the vitamin K trial. Upper right, the active A trial. Aspirin with clopidogrel is not an adequate substitute. 77% more strokes in the aspirin clopidogrel trial led to that trial being stopped prematurely. 25% of patients in the trial in the active W trial who were not felt to be vitamin K antagonist candidates went on to vitamin K antagonists anyway. And in more recent years, we've got evidence, particularly from the Aristotle trial, that use of a newer oral anticoagulant, a direct-acting drug, is superior to a vitamin K antagonist. So there's no getting around this. We got good drugs and good evidence that they work. The bad news is, if you take a look at the lower left, you've got to be fully anticoagulated to get the stroke presentation. These are Elaine Heilig's data with warfarin. We see similar curves when we look at drug levels for dabigatran and stroke risk. With the appropriate transformations, you've got to cross a certain threshold to have a benefit. So if you have atrial fib and you haven't had a watchman in place for a long time, there's not much getting around using an oral anticoagulant in an adequate dose. This is the case in about 7% of patients who receive stents. In virtually every study that reports it, 7% of stents have an indication for oral anticoagulation. There have been 5 randomized trials done. We won't go through all the details of them, other than to say that in every trial, even the ones that use full dose oral anticoagulant that's known to provide stroke protection. Double therapy, the anticoagulant plus the P2Y12 antagonist beats triple therapy. So with the newer drugs, there are about 8,000 patients in the randomized trial. A nice meta-analysis has been published by the group in the UK. Like everything else, I'm sure we're going to see a whole slew of meta-analyses coming. That's the way the world works. To sum it up, high certainty evidence that dual therapy was associated with reduced risk for bleeding compared with triple therapy. Low certainty evidence showed inconclusive effects of dual versus triple therapy on risks for ischemic events. In most of the trials, they were either the same or lower. They were not higher. The one we all talk about is the largest trial, Augustus. We're not going to go into a lot of detail other than to show you it was a factorial 2x2 design between apixaban and a vitamin K antagonist, and aspirin versus a placebo. The P2Y12 antagonist was 93% clopidogrel. These are the primary findings. At the top, bleeding less with apixaban than a vitamin K antagonist, bleeding considerably less with aspirin than a placebo. No kidding, guys. Fewer anticoagulant drugs, less bleeding. Hey, glad everyone came to grand rounds. But take a look at the bottom. No appreciable differences in the rate of ischemic events. I'm sorry if that's tough to read. Stent thrombosis. Hazard ratio 1.89 actually favors placebo and favors the newer anticoagulant apixaban. Confidence limits way on the other side of 1. Similarly, there's maybe a hint of increase in stent thrombosis, but the absolute event rates are low. Hazard ratios, again, well on the other side of 1. Landmark analysis, again, after 30 days, the differences are pretty profound. But take a look. I've shown you only the aspirin versus placebo curves here. It actually turns out that the number of bleeding events you prevent by not giving aspirin during the first 30 days are equivalent to the number of ischemic events you prevent. So I wouldn't say this favors not using aspirin acutely. You might interpret it that way, but you might interpret that there may be some ischemic benefit during the first month when stent thrombosis rates are high. And maybe if this analysis were done at 14 days, it might even look favorable. So perhaps, perhaps there really is a subgroup of patients who've got AFib, who've got complex stenting, who really worry you about stent thrombosis. Maybe a very short course of triple therapy, perhaps lasting 30 days, perhaps lasting less than that, may be indicated. We don't know, but as you try to wake up after grand rounds, it might be something to think about. Okay, theory is great, but let me ask you this. What if there were no hypothetical questions? Great cardiologist George Carlin said this a number of years ago. Well, again, bleeding and thrombotic risks track together. Third time I've shown this slide. Don't forget it. Here's a case that probably led to a pretty uneasy night's sleep for the interventionalist. Pretty diffusely diseased circumflex, a long string of stents, probably 120 millimeters. This is a guy who's at risk to develop thrombosis. I actually stole this from someone else. I don't know any details about the patient, but I can guarantee you that the operator didn't go home feeling really good that day. So a number of models have been developed to predict one's risk and a benefit for more prolonged antiplatelet therapy. After all, if bleeding and thrombotic risk track together, you got to have some way to figure it out. And suffice it to say, there are a number of projects going on now to develop current usable risk scores for current stents implanted with current techniques. There are a few that are in the literature. This is the most widely cited one. It's the Dapped prediction score. Remember, if you're going to use this score, it's readily available, and it's used to predict the benefit for dual antiplatelet therapy after a full year of treatment. So this score is not designed, it's not taken from a patient pool starting on day 1. It's starting on day 366. So a patient's gone through a prolonged period of DAPT, they've done well. Now, do I want to continue it or not? It's one of the frequent things patients ask you during their 1-year follow-up. Do I have to continue taking all this stuff? This risk score is calibrated for the DAPT trial, so some patients, for example, those taking oral anticoagulants, are excluded from it. But, you know, the calibration's not so great in a broader population. So this is undergoing refinement. Another score designed to look at short, meaning 3-month or 6-month, versus long DAPT that's been developed is the precise DAPT score. This is also readily available. It's been derived in one group of studies, validated in another. And if you take a look, it's pretty easy to use. You take a look at these characteristics down in the bottom left, put your cursor on them, and then scroll up and you get the score, a number of points. You take the score, add it together, and you can produce a precise DAPT score. And then that score is going to put you into one of 4 categories: very low risk, moderate risk, and high risk. These curves are meant to show you the net benefit in terms of ischemia and bleeding. And they show you there is an inflection point where there's harm from longer DAPT than shorter DAPT. That inflection point occurs with a risk score somewhere about 15, 16, 17. You can see the black curve, which is the net benefit, takes a sharp downward curve there, and at about 25, 26, it crosses the line of unity, showing that there is harm for shorter DAPT, for longer DAPT in those patients. This stuff's being refined. Again, it's derived from a set of randomized trials, selected patients. So the use of risk scores in the European guidelines gets a Class 2B indication. It says that, you know, they're still under development, not completely satisfactorily validated. Okay, so we're out of time. Precisely what do we need? Well, we need to recognize now that bleeding and thrombosis are not independent arenas. If you're at risk for one, you're at risk for another. As one of my fellows said very succinctly a few years ago, Dr. Kleiman, risk is risk. Those 3 words sum it up really nicely. We need indices that have just shown that are calibrated to broad populations. And I think we need to recognize that risk is graded rather than dichotomous. If you stop DAPT, it doesn't mean that your patient will necessarily develop a stent thrombosis and myocardial infarction during the next week. The risk may increase, but it's a graded risk rather than an absolute risk. And I have 50 more slides to go through. I think we probably should.
We're going to invite you back for another grand round.
Okay, sounds good.
So let me. So first off, I want to introduce. We have 2 of our interventional colleagues here, Dr. Stuart Solomon and Dr. Alpesh Shah, and I invited them to come online here so that they could challenge you a little bit if they wanted to.
I'm up for a challenge.
Stuart, Alpesh.
Can you hear me, Dipan?
Yes, I can hear you.
Okay, so quick comment. Dr. Kleiman, you've taken us from the Big Bang to Star Wars, and I'm really not sure that anybody else that I know of in the field could have done such an excellent job. It breaks my heart to compliment you so well, but I do think you deserve.
Boy, can we edit that out? We'll edit that out, Stuart.
Tremendous amount of congratulations for
Thanks.
that. You and I have come to clash professionally on numerous occasions. When I ask you the question, talk about how long you're going to keep your PCI patients on dual antiplatelet therapy. And you've always said forever. And I said, show me one study that will prove your point. Now, listening to you today, okay, I've seen a lot of evidence that you present. If you talk about the Dapped trial, it seems that there is an advantage for dual antiplatelet therapy in some respects. Then if you talk about the 2019 and 2020 trials, that there's an advantage for just going with one antiplatelet therapy, ethanopyridine drug. So can you comment on how your research for your grand rounds is going to change what you do in your practice? Because remember, most of us out here don't have the encyclopedic knowledge that you do. We're clinicians and we try and treat our patients practically.
Yeah, so I think, I think this. I've been pretty firm about recommending prolonged Dapped. I think I've loosened up in the last year. If you take the rare patient, and we don't see a lot of these. We'd love to see them. 45-year-old, big, robust guys who pump a lot of iron. Got a large body mass, who are 45 years old, have a really discrete lesion that ends up with a really short stent. I mean, hell, I can't remember the last one I saw. But a guy like that, says to me, Kleiman, how long do I need to take this? Actually, I do remember the last such guy, so it's been 3 years. And I think he's on my schedule for this afternoon. He's going to ask me, how long do I have to take this stuff? And, can you...
He's actually on my schedule, Neal.
Oh, okay. Well, clinic. I said, I don't really know, but you're tolerating this stuff really well. You may develop future things in down the road. Why don't we keep you on it? I think I'd probably lessen up on that a little bit. I'm not certain.
So you haven't really changed, in other words.
Well, if he were 70 and said, every time I bump into something, my wife thinks I've been with my mistress, then I'd say, okay, I don't want to get in the way of your marriage. Stop the aspirin.
Okay.
But that sort of leads us into the question that Sachin has posted here. Is this visible?
Yeah, I'll get to that one in a second. Next, Alpesh. I want to give Alpesh a chance to...
Well, thanks, Dipan. Again, hats off to you, Dr. Kleiman, for such a wonderful presentation to cover depth and breadth of such a complex topic. It's an absolute mastery, so thank you so much for that. Dipan mentioned the word challenge, so I'm going to give you a little provocative question, and I would love to know what your views are. But it goes to this efficacy, or the need rather, for aspirin peri-procedural. I'm talking about literally day one in the cath lab, or even the first 30 days, as we have collected all this data over the last 10, 15 years about less and less need or benefit of aspirin, and a higher risk of bleeding, maybe beyond 3 months, beyond 1 month, as given in the form of a Dapped. And this also extends to the clopidogrel, where the effectiveness is not always consistent, especially compared to some of the newer P2Y12 molecules, such as ticagrelor or prasugrel. I look at this sometimes as like a new car. You have a new car available, it smells better, it looks better, it drives better, it's safer, it gets into less accidents, but some of us are still stuck to our red old Porsche. So the question is, why not just drop aspirin completely from day one? And I'm going to challenge you. I'm very curious about your thoughts. And just start with ticagrelor from cath lab, and that's it, monotherapy.
Well, if I were really pompous, I'd say, well, we have no randomized controlled studies. But the truth is, that's a great question. I don't know the answer. What I do know is that at least in the triple versus dual therapy trials, everyone got aspirin at the time of their PCI. And I really think that the downside of giving a few doses of aspirin is pretty low. Remember, this is cumulative exposure we're talking about. The day when you and I were young and we worried about bleeding, we worried about acute groin bleeding when we used lots of heparin and P2Y12 antagonists and and thrombolytics. That we don't do anymore. In fact, often we stay away from the groin entirely. So I don't know how critical a question the first few days is. I think if the downside is low, and we know that most stent thrombosis occurs within the first week, I'm not in such a rush to drop it. I don't think that that's a critical decision point in patient care.
Just to follow up, however, we do know that most of the bleeding events are happening within the first 7 days or first 30 days. And if the role of aspirin is such a highly debatable topic now, is it unethical? Is it medically unfeasible to even ask this question about monotherapy from the get-go?
Well, remember, most of the access site bleeding events are the ones that occur acutely. And I would bet if you looked at non-access site bleeding, which is worse than access site bleeding because it's an indicator that you've got other things going on, I would bet that most of the early non-access site bleeding we see in patients who are critically ill, who come to us from the intensive care units, or who got something going on. I think that's a great point. I really would like to know which patients develop those problems. But I don't think, I still have a hard time thinking of aspirin tablet in the peri-procedural period, maybe 2 days. Remember you've got some effect for a week. I don't see that as a critical decision point.
But Neal,
Yeah.
don't we, when the standard of care sort of has become, and please correct me if I'm wrong, but hasn't standard of care for triple therapy patients, the AFib patient with the stent, become give aspirin just on day one and then just single agent phenylpyridine with resumption of a NOAC, they're on day two going forward?
Yeah, either day one and day two, or then dual therapy after that.
All right, we've got a question from Sachin Goyal, which I think is actually similar to what Alpesh asked, which was really, could you do SAPT alone after PCI? So I think we've gone through that discussion. Can I see the next question? It says, clinical scenarios where Dapped could be considered long-term in patients post-ACS if there's no bleeding observed within the first year. Do you do that decision based on anatomy, based on?
Well, again, the Dapped score, interesting, I should have showed this slide. Remember I showed you the precise Dapped score and the Dapped score. So again, our knowledge is really limited to the Dapped trial, which treated everyone for a year. The Dapped score, back up. The precise Dapped score is based on angiographic findings. When you apply it in the Dapped trial, it doesn't tell you very much. So unlike 3 to 6 versus 12 months, where the precise Dapped score is pretty good, it's not so good after 12 months. The Dapped score is designed for that, and that's based on clinical rather than angiographic findings.
Okay.
So Antonio Colombo had a nice editorial when one of these scores was published, and said, look, after 12 months, it's the clinical scenario that should determine whether you continue Dapped.
All right, let me ask you let me pose another question. So we talked a lot about Dapped and we talked about SAPT, single antiplatelet therapy.
Yeah.
What about NAPT, no antiplatelet therapy? The scenario I'm talking about is you have a patient that comes in with acute coronary syndrome, but they also have something else, a malignancy that's also found. They're going to need surgery within the next month or 2 months. When can you, but they need a stent for their acute coronary syndrome. What would you do? How would you handle that patient? When would you feel comfortable stopping?
Okay, so that's a great question because it's not just malignancy. We see this in preoperative patients, and we debate it, and no one really knows the answer. I think based on all the data that are out there, you ought to be using a current generation drug-eluting stent. Now, does everyone agree with that? No. If they're going for surgery within a week or 2 weeks, probably you shouldn't. And actually, if you go back to the early generation bare metal stents, there is a publication from the Mayo Clinic that indicates 2 weeks may be adequate. So possibly if you're going to surgery, within a week or two, that's what you ought to do. That's not usually the case. Usually we're looking at 4 to 8 weeks.
All right.
And usually it's a patient who comes in with an ACS because the data would tell you that stenting stable coronary artery disease
Right, you
doesn't lower your surgical risk,
Yep.
despite our oculostenotic
Yeah.
reflexes. So I think in that case, you ought to go with a current generation drug-eluting stent and a month of Dapped.
Okay.
Now the issue comes up to use a short-term intravenous drug, and there's only one, that's Cangrelor, as a bridge. And there is one study known as the Bridge study that looked at that, but really what they looked at is during the pre-op period. And your risk appears to start during the post-op period when patients are still bleeding, they still have drains in, their prothrombotic system's revved up. And that's probably a situation where you don't, you want to hold your breath and not give an antiplatelet drug for a while.
Great.
Assuming they're continuing to bleed and
Right.
not sealed nicely.
All right, well, great. So I think we're a little past time, but I think it was a very nice discussion. So one, I want to thank Neal for an outstanding presentation, as always. And I want to thank Stuart and Alpesh for posing some challenges to Dr. Kleiman. And I guess we'll look forward to seeing everyone in 2 weeks. Thank you.
Thanks, guys.
Thanks.
All right, very nice.
What's next week?
Oh, next week, there's no grand round.